Thank you, Renzo. Thank you, friends, and a special thanks to all my colleagues around. I will not talk about any drug or medicine during my talk because this is just islet plasticity. So what's the destiny of our islet cells during the appearance of diabetes? But I would like first to thank all the friends who made this invitation here. And you will find all the scientific committee within this old slide, dated 1990. That's me, Simona Frontoni, Anna Solini, Ralph Lefronzo, Riccardo Bondonna, Stefano Del Prato, Agostino Consoli, all the scientific committee. So I thank you all for inviting me. And Enzo Bonoro, of course. Where is he? He's here. Sorry. Okay. It's an old story. I think we all know this old slide drawn by Ralph Lefronzo during his major talks, telling us the natural history of type 2 diabetes. We now very well know that before the appearance of diabetes, the appearance of insulin resistance is highly compensated with an increase of insulin secretion. Here is in yellow, the insulin sensitivity decreases and compensated by an increase in insulin secretion. And then diabetes appears as for the reduction of insulin secretion during time. In all these years, I always studied the pathogenesis and the mechanism and everything about insulin resistance, but really the appearance of diabetes, and this is very clear in these slides, comes from the reduction of insulin secretion. So during these last years, I really tried to understand where is the mystery that actually is responsible for the appearance of diabetes in our patients. Well, one of the major things might be the reduction of insulin mass. Less beta cells, less islets might determine a reduction in insulin secretion. Here is the same line we've seen before, the compensation and then the decrease. And you see that more or less there is a sort of correlation between the islet mass and this insulin secretion. Third, normal glucose tolerance, you will see there is a large variability because maybe somebody is here at the very beginning of the insulin compensation and somebody is here. So putting all together normal glucose tolerance is not very nice to really understand how islets compensate for insulin resistance. Then, I think 7 or 8 or even 10 years ago, I was very lucky because a surgeon came to my room. He was doing some pancreatectomy, and he asked me this very question. I always use exactly the same procedure for partial pancreatectomy. Why do some patients get diabetes and while others don't, if the surgery is just the same? I mean, patients come to my surgery room without diabetes, and some of them then get out with diabetes. Why is that? Well, why the same procedure? Here is the anatomy of the pancreas. We should remember that from the embryogenic of the pancreas comes from the right side and the left side, so the arteries still come from the right and the left. And for this reason, surgery are required to do partial pancreatectomy always on the same side, even if the tumor is on the papilla of Vater, so there is no pancreatic tumor. Still, to remove this part, they have to remove all the head of the pancreas. So really, the pancreatectomy procedure is always the same with this procedure. But with that, we also realized that removing this part of the pancreas, we had available a large part, all the head and some of the body of the pancreas, to perform studies in order to understand what's going on in the islets. So really, with this normal tissue, remember that the tumor is in the papilla of Vater, we can really understand what's going on in the islets of these patients. As mentioned, I'm not an in vitro researcher. I'm always working patients during a clamp study or things like this. So we really designed a very complicated procedure and studies approved by the ethical committee and also written in the clinicaltrials.gov, so that any patient who goes to this kind of surgery, we do a euglycemic clamp in order to determine if they are sensitive or resistant, then an oral glucose tolerance test to really understand if they are normal or diabetes. We measure insulin secretion with the state-of-the-art procedure of the hyperglycemic clamp, and then in order to verify the incretin effect, we also do a mixed meal. Then patients go to surgery, we get some biopsy, and after all this, after 1 month more or less, we repeat all these studies. And all the results you will see will come out from this procedure. So, as you can see on the left, insulin sensitive and insulin resistant. By definition, obviously, these have glucose uptake which is higher than this, but all the other characteristics are more or less similar. And obviously, insulin resistant patients, as we already know, have an increased insulin secretion during the hyperglycemic clamp, so with an increased first, second, and also the arginine plus the hyperglycemic clamp. That's very normal, very known. What is important is to understand that what happens after the surgery. You will see here, this is the first phase of insulin secretion, which was increased in insulin-resistant subjects. What you will see is that after surgery, there are no major changes in patients who are already insulin sensitive, while the first phase is really largely decreased in alpha before. And together with this, we also have a major increase during the mixed meal yield and glucagon secretion. So really we can get some kind of answer to our surgeon. But also another important note is the fact that also these patients, we were able to measure the pro-insulin ratio, and these are the insulin sensitive. You will see there are no major difference, while here they start from higher number, but the difference is that after the surgery, the squares, you will see that the pro-insulin ratio is increased, meaning that there is some kind of stress in secreting the insulin, so that more pro-insulin is secreted together with the regular insulin. So our answer to the surgeon was that insulin resistance plays a major role in post-surgery glucose homeostasis. People who are already insulin sensitive do not change the insulin secretion after the surgery. On the contrary, those who come from insulin resistance, the previous stress is able to reduce the insulin secretion. So really, the major reason for that is not what happens to the pancreas, but what is present before the surgery, insulin resistance and the consequent hyperinsulinemia, so that these patients are not able to cope, to compensate with the beta cell reduction. As I mentioned, we had the chance to study these pancreatic samples, so we started together with Roy Kulkarni and Teresa and then other people. You will see actually flew to Joslin, the diabetes clinic in Boston. And here you will see that as we can expect, in this patient with insulin resistance, there is an increase in the beta cell area, alpha cell area, and the delta cell area. This is a large islet, really much larger than insulin-sensitive subjects. As here you will see is the islet size, once again insulin-sensitive and insulin-resistant, so really telling us that these islets are larger when insulin resistance is present. It's not just if you divide subjects into resistant and sensitive, but there is also a very nice correlation between these two parameters, so that as soon as the glucose sensitivity goes down, there is an increase in islet size with this very nice correlation. So some first conclusion is that we know that in order to compensate not to diabetes but just to the presence of insulin resistance, we humans are able to increase the beta cell mass with some kind of mechanism that still we have to understand. What might be this mechanism? Well, here, one again, you will see that the beta cell size as a mean is not very, very different between the two, but the major difference is in terms of islet density. There are more islets in patients with insulin resistance, and these more islets are larger, so the large ones are more, and the small ones are more. And the fact that the small ones are more means that maybe new islets are coming out. It's also seen in these scattered islets, which is a sort of marker of regeneration of islets. Maybe the mechanism for this increase in islet is neogenesis rather than other changes in the islets. Neogenesis coming from where? Well, we already know from other experiments that some of the beta cells might come from the duct cells, who might transdifferentiate. You will see some insulin immunoreactivity in these clear duct cells, and these are really much more present in patients with insulin resistant as compared with insulin sensitive. And another brand new source of islets might be this new thing that has been found around, which is the transdifferentiation. Here you will see glucagon in green, insulin in red. If you put them together, you overlay these two different colors, you will see somewhere there is some yellow, meaning that there are some cells who actually are positive for both insulin and glucagon, and these are really increased in patients with insulin resistance. So suggesting us that this transdifferentiation, at least colocalization of insulin glucagon, is more present when insulin resistance is there. And notably, this is particularly present in islets with at least 50 cells, meaning that the larger islets have this kind of transdifferentiation between these two cell types. So together with neogenesis, we might also have a transdifferentiation from maybe alpha to beta, who knows, and then also for certain some transdifferentiation from duct cells. Just to summarize this first data, since certainly a reduced insulin sensitivity triggers beta cells expansion, I'm sure that we can affirm this, mainly through transdifferentiation, either from duct or from alpha to beta. The question is, can we identify what is the main characteristics together with insulin resistance that triggers this transdifferentiation? And another question, important question, is why there is such an increase in alpha cells. Well, trying to get some more data on how insulin is secreted, we started a cooperation with Professor Andrea Mari in Padua. He knows everything about on how to interpret the data of insulin secretion with this glucose sensitivity, which is a very sensitive way of calculating insulin secretion according to the different glucose concentration. Here, as you will see, even if the insulin secretion was higher in insulin-resistant patient, you will see the insulin sensitivity is decreased. So there is a decrease in the way these patients are able to decrease their insulin according to the glucose concentration. And once again, we could find a nice correlation between the islet size, where you remember insulin resistant here, but this time also with this beta cell glucose sensitivity, this way of measuring insulin secretion, so that the higher the islet size, the lower the insulin is able to produce insulin to a certain glucose concentration. And finally, going back again to the double positive cells here in yellow, who were both glucagon and insulin present, you can even find a higher correlation. You will see that really they are really laying on the line correlating glucose sensitivity and this number of double positivity cells. Maybe so the increase in alpha cell and glucagon are somehow involved in these changes. This is once again the insulin sensitivity during the hyperglycemic lamp. You will see there is a nice correlation, negative correlation with alpha cell area, meaning that the higher the alpha cell area, the lower insulin sensitivity. And these are the clear, at least five-fold increase of alpha cell area, both in absolute terms as compared to the whole pancreas area, but also in terms of alpha-beta ratio, meaning that both alpha and beta are increased, but alpha are more increased than beta. So really there is a large number of alpha cells around. maybe these cells are able to do some GLP-1. You know that GLP-1 is secreted, comes from the same gene of glucagon. Here we can find a nice correlation between the GLP-1 secretion and, once again, the alpha area, suggesting us the higher the alpha cells, the higher is the GLP-1 in the whole blood. And also, after surgery, when there is this reduction in the islet mass in the pancreas, you will see there is an increase in GLP-1 secretion. So really suggesting us that GLP-1 might be a way to compensate for the insulin secretion deficit. And maybe these alpha cells are there for this purpose. Another suggestion actually comes from my chairman, Piero, who was able to demonstrate that DPP4, the major enzyme to regulate GLP-1 activity, is actually expressed in both alpha and beta cells. So if it's there, must have some kind of action in order to regulate GLP-1. Together with Jay Holst, we try to understand if GLP-1 is really present, not in the plasma, not in the gut, but within the islets. And there is some suggestions here that at least the C-terminal is present in these islet cells, but also as compared, even if as compared with the other hormones, as compared with glucagon, these concentrations are not very high. The absolute concentration may be not that important because we just need maybe a few molecules of the hormone in order to exert its effect on insulin secretion or insulin, let's say, regulation of islet mass. But still, we have to finally demonstrate that GLP-1 locally has some kind of action. But it's there, and so being there, it might have some action as well. So reduced insulin sensitivity triggers beta cell expansion, mainly through transdifferentiation from duct and maybe alpha to beta. Reduced beta cell glucose sensitivity seems to better predict islet expansion. And we also noted that alpha cells are increased and GLP-1 is present, or at least is also increased in the alpha cells. We don't know why it's there, but there must be a reason why GLP-1 is present in the alpha cells within the islet. And we also try to understand if there might be also some other possible mechanisms which are regulating these changes in the hormonal secretion of the islets of our patients. Another good way to really understand what's going on in these islets is to take them to somewhere where they are able to do proteomics, which is not very easy. It's very easy to perform, and mostly it's difficult to understand what's going on because the results are really complex. It's time to understand all the proteins which are really changed. Here we compared non-diabetic insulin resistant with insulin sensitive with diabetic subjects, and you will see these 156 proteins were differently expressed, 83 here, 44 here, 9 here, so really trying to understand and putting all these proteins together to understand what's going on is not easy, but we try to summarize these results, revealing that this PAK2 is decreased, whilst the cell 1L is increased, suggesting that there is an increase in the cellular processes of these islets, suggesting that these proteins might be involved in the transdifferentiation of the pancreatic cells, both from alpha to beta or from duct to insulin-secreting cells, but also that there are changes in metabolic processes, and maybe also in the folding and in the preparation of insulin. We will see something later on, really trying to understand that many changes are present in these islets, and they are really conducting this attempt to maintain normal glucose homeostasis in the presence of insulin resistance. One of these, which is cell 1, once again, is really related to the glucose sensitivity as measured by Andrea Mari, It might be that this is one of the proteins that is involved in the regulation of the islet plasticity of our islets. As we already seen, there are also changes in the proinsulin production. You know that proinsulin secretion means that insulin is not really ready to be secreted. And so we also started a cooperation with Francesco Dotta in Siena, really trying to understand what's going on in the secretion of proinsulin and insulin. You will see these are in a normal subject, impaired, and type 2 diabetes. You will see that merging this, there is really an increase, especially in the proinsulin production. And I think it is more evident here. Maybe there is too much light, but generally speaking, you might see that there are no major changes in the green part, the insulin monoreactivity, while there is an increase going from normal glucose tolerance to type 2 diabetes in the red part. If you don't see it, please trust me. So putting them together, the meaning is that rather than producing less insulin in general, these islets are not ready to produce mature insulin. They actually attempt to do it, but the final result is to produce a large secretion then of proinsulin, which is then not very active in determining its insulin action. And once again, we also try to correlate these results with the parameter done by Andrea Mari. So mostly we didn't do anything here because this has been done by Francesco Dotta and this has been done by Andrea Mari, but still the samples are ours. And once again, you will see that there is a very nice correlation telling us, suggesting us that this glucose sensitivity or the reduction in glucose sensitivity is probably the major driver of the islet adaptation to the presence of insulin resistance. So going back to summarize these results, we can suggest that reduced insulin sensitivity triggers beta cells to transdifferentiation. Several changes in the cellular metabolic processes are present in the islets, resulting, at the very least, in incomplete insulin generation in favor of proinsulin, which is not as active as insulin is. And then we will try to understand why are we doing this and why then these changes are actually bringing us to the presence of diabetes. Well, this is more or less the same slide at the beginning done by Ralph, normal, compensation, and then presence of diabetes. And we are now aware, especially from the results of the data done by Mimmo Acili, another Italian working at Columbia University in New York, that one of the major characteristics of the islets in presence of diabetes is not apoptosis or things like that, but rather than differentiation, which means that these cells present in the islet are still endocrine cells, but then they are not positive to any of the hormones which are usually present in islets. So it's a sort of a sleeping cell, a sleeping beauty waiting for better moments in order to going back and produce insulin secretion. And this has been done, these results, by Francesca Cinti, who joined our group recently. Another manuscript done by Francesca, not with us, before coming to our group, is that the differentiation of islets is also accompanied, at least in a mouse model, with an increase of noradrenergic fibers, so suggesting us that this different innervation, or at least this increase in noradrenergic fibers, might be responsible for the differentiation of the islets, so sort of the final end of the journey toward diabetes. And together with Piero, where we are collaborating, actually, this data, we are trying to understand whether there is an increase in noradrenergic fibers in our subjects. These data are not together with Piero, but we are collaborating with him anyway. And here you will see that these fibers are increased, going from normal glucose tolerance to diabetes mellitus. And once again, there is a very nice correlation between the presence of these noradrenergic fibers and beta cell glucose sensitivity, which once again is the major parameter which tells us what our beta cells are doing. So once again, summarizing, we now understood that there is a compensative mechanism from transdifferentiation neogenesis able to cope with the presence of insulin resistance, so that there is an increase in beta cell, but also an increase in alpha cells, maybe producing the GLP-1. But then through the differentiation, that's sort of going to rest of these endocrine cells, some of these cells stop in producing and secreting hormone, waiting for better times. Trying to really find a history of this journey, let's say a logic way of representing all the mechanisms, we might suggest that in the presence of insulin resistance, but still without any diabetes, beta cells are stressed, and in response to that, they try to remodel, increasing both the beta coming from transdifferentiation, but also the alpha cells. You will see here transdifferentiation of the alpha, the duct cells, and maybe also some neogenesis. Then this also determined an increase of both beta but also alpha cell mass, and that this alpha cell mass might be able to certainly increase the GLP-1 immunoreactivity, and we might suggest that there is also an increase in GLP-1 production locally within the islet. And you can imagine that the power of the local intra-islet GLP-1 secretion might be very powerful in determining preserve the increasing effect and eventually able to preserve in the beta cell function of these subjects, so that even if there is a long-standing insulin resistance, until this mechanism is able to cope with this beta cell stress, beta cell function will be kept. On the contrary, there is somehow some kind of triggers which might be modulated by really reduction of glucose sensitivity, which might determine an increase in noradrenergic fibers within the pancreas and the islets, which in turn might determine an increase in the differentiation, so that these islets are not able to produce insulin and the general hormones, and the hormones produced in the islet, generally speaking, and then at the very end, the differentiation will actually determine the presence of diabetes. A few slides of really to thank all the people that have been around in producing this data. This is a picture during last summer. That's me, Teresa, Chiara, Walt Kulkarni, Alfredo Pontecorvi, who's my chief, and this empty chair is Francesca, who just delivered Rebecca. We will also note that water bottle is full while the wine is quite empty. We were all drunk during that night. Just to thank really Francesca, you will see him as major role here in this review, where you can find all the answer all the questions you might ask. Thank to all the people who are staying in Rome while I'm here, together with Teresa and Francesca and a couple of new fellows, but obviously, as any other day, people is there working in order to keep our patients under control. And a very special thank to my family. Thank you.
Thank you. Thank you very much, dear Andrea, for this very elegant and interesting talk on this trip from the patients to the islet molecular features, and also, I would say, return in terms of prospective solutions for the problems that you underline. Andrea has touched a lot of very interesting, novel, and debated issues, and so I'm sure that the discussion will be very active. And I would start by inviting our young colleagues to begin and ask about points that Andreas touched or others that people might have thought about during the presentation? We have a young colleague here, please, Professor Cordera.
Just to start, interesting data, but
we have a very young fellow here, Renzo.
You didn't talk about lipotoxicity.
Huh?
You didn't talk about lipotoxicity.
Okay.
That is play a major role in beta cell failure. And just to recall, if you look at the morbid obesity, people with a BMI more than 40 that undergoes bariatric surgery, in just a few weeks, less than 1 month, you restore the first phase insulin secretion. But the same thing doesn't appear in the people with lower body mass index. So I think that first comes the overeating, obesity, insulin resistance, lipotoxicity, and the journey comes going back, just reducing calories.
You are extremely right. Really, I perfectly agree with you. I didn't have the chance to show very, very preliminary results done by Francesca sitting there. The point is that usually when there's pancreatic samples are prepared, triglycerides, lipids are removed. So usually the content in triglycerides is not seen. Francesca, who knows very well the role of obesity for several reasons, did some preliminary experiments, really trying to understand if some lipids might be present in these samples. And really there is a nice correlation between the presence of triglycerides and some parameters of insulin secretion. Didn't have to show these preliminary results, especially because they are very preliminary, so we try to figure out all the things together. But I absolutely agree with you that the content in triglycerides in terms also of lipotoxicity, but not generally speaking of free fatty acids circulating, but also triglycerides present within the pancreas and maybe within the islet might be responsible for some changes in insulin secretion. And obviously, this is very well related with the metabolic syndrome, obesity, and especially central obesity. So you are absolutely right. This is another future field of research we are hoping to do in the future.
Other questions, comments from the audience? If Enzo forgives me, I see 2 hands over there. Well, it's live, so I thought it was someone else.
Definitely not from a younger colleague. Right. Andrea, it's a very nice talk. Do you know that for the surgery, does it remove equal amounts of exocrine and endocrine pancreas? That's my first question. And my second, when you said expression, did you have RNA sequencing data from after surgery so you could see, how the genes are, the expression of genes change?
Okay. First, yes, the answer to the first question, the surgeon removes always the part of the duodenum and the head, a little part of the body of the pancreas, both in the endocrine part and the exocrine part, because, as I said at the beginning, arteries are there. Once you remove that, you have to remove altogether, and then the rest of the body and the tail of the pancreas is attached again to the gut. So yes, there is also some reduction also in the exocrine part of the pancreas. The term expression might be not really correct. What I mean is presence of immunoreactivity of these hormones in our preparations. So we don't have actually mRNA determination in these samples, but we might be doing it in the future for sure, trying to understand there is differences in expression of different proteins, except for the proteomics which are showing you, which are not mRNA, it's a proteomic.
I would how to say, Pierre probably could help you.
No, I have participated to a project in which people from Dresden have prepared by laser capture microdissection islets after removal of the pancreatic areas affected by the tumor. And actually in that project, the main aim was to compare the transcriptome of non-diabetic samples versus type 2 diabetic samples. And there were indeed some differences. And when these differences were matched with those found in the comparison of non-diabetic isolated islets from organ donors versus controlled samples, type 2 diabetic versus controlled samples, there was an overlap between the pancreatic data and the organ donors data regarding, in particular, 19 genes which were differentially expressed between the two categories, non-diabetic versus type 2 diabetic. And I appreciate that whoever Andrea is trying to answer some kind of different questions rather than simply comparing the diabetes status.
Yeah, I think the major question I tried to answer was rather understanding why diabetes appears, we are trying to understand how beta cells, or at least islets, are able to cope with insulin resistance and where this process fails, so at the very end, diabetes appears. So rather than looking at losing the beta cells, I think that the major reason is why we are not able to increase more the beta cells. We know that there are many patients who are severely obese, they might have 50 of BMI, and they do not have diabetes at all. So it's not rather than a failing beta cell, rather than the failing in compensating beta cell. I think the major reason for diabetes is there.
And so, no, but you have room now.
Thanks, Andrea. Fantastic talk. Very, very nice data that you are collecting. Question. We are accustomed to think, and Leif showed that clearly, that there is a great heterogeneity in type 2 diabetes. So I'm wondering if I understand that getting many pancreata is difficult, but I'm wondering if the journey is different, for example, in younger than older people undergoing surgery, of course, or more obese, not obese individuals. I mean, that if you can identify signatures in terms of, for example, of proteomics or in other steps of what you are looking for that can differentiate the journey toward a failure of the beta cell according to the age of the people, starting age, of course, or the degree of obesity or other clinical features.
Yeah, the point is very well taken. Certainly we try to do it for the few samples we have each time. The major limit of this kind of research is that we are not following patients. We just have a wonderful picture of each single patient each time during his history, meaning that in that days we do all the clamps, then we take the pancreas and we study the pancreas, but we don't have nothing to follow except for pancreas or what was going on before. So the first slide I showed, which is the natural history of diabetes of Ralph, is actually the same method. He didn't follow up patients at all. He simply put all the patients together, and we are trying to do the same, trying to see with all the single pictures we might really draw a natural history of the islet compensation and decompensation. And then, after that, really try to understand where all the factors, as obesity or age or whatever, are influencing these results. For sure they are there, and I'm sure that collecting more and more samples, we will be able to answer to these very important questions.
One more question there.
Roy Taylor, Newcastle. Andrea, a splendid talk and just great data. You showed us very nicely in your surgical study at the start of your talk that insulin resistance correlates with islet size. Now, it's been known for some time that the more obese a person is, the larger the islets. And I just wonder if your data set is large enough to be able to dissect these two components. Because, of course, at any given BMI, there is a wide variety of insulin resistance, or to turn it round to what it actually is, insulin sensitivity. So if you were to look within bands of BMI, is the correlation still there? Or alternatively, is the correlation with BMI and islet size stronger than that with insulin resistance? It would be nice to pull apart these two factors.
Yes, your point is very well taken, meaning that insulin resistance might be secondary to obesity by itself, also by other components. So trying to dissect how to correct, as usually is performed in statistics, when you have a correlation corrected for something, obviously BMI is one important parameter. Unfortunately, the number of samples is not sufficient to do this kind of correlation. We are talking all our history about, I don't know, for sure less than 100, but maybe something around between 50 and 70 patients up to now. I mean, pancreatectomy is not that common, and I'm obviously happy for this for the patients, not for our research, but they're not that common. And so even the patients have to be, let's say, healthy enough to do all the studies we do before, because as mentioned, we do oral glucose, mixed mean, hyperglycemic, euglycemic clamp, so they have to be very severe and very sick. But your point is very well taken, more or less the same as Enzo said before. There are many variables which might influence the presence of insulin resistance, as you mentioned, but also the presence of deficit of insulin secretion might be influenced by these other parameters. We will do it in the future for sure, and we'll try to, maybe the next 10 years, and when I will come after the next 10 years, I will tell you these new results correcting for age, obesity, and whatever.
Andrea, in following the steps of your talk, I would have 2 or 3 short questions. First one is if, to answer your surgeon, the family history for diabetes of the patients could be part of the answer. The second one is a sort of, let's say, common question that when we talk of these topics arises. The causes of surgery and in your patients, and whether the type of lesion that led to the surgery might affect some of the findings, so that people here will understand clearly this key point. You mentioned the locally produced GLP-1 in the islets. I think it's very true that in non-stressed or in minimally stressed islets, GLP-1 expression locally and production locally is low. And I wonder whether you had similar data after the islets were exposed to stressful conditions, because GLP-1 there could be a way of defense. And the very last one, in the proteomic approach, what kind of techniques did you use? Were there, laser-captured islets or tissue processed in some way?
Yeah, so with the last one was a laser capture done by Chiara Cefalo 1 year ago. Okay, let's go back. The third one was on GLP-1. Yes, the idea is that there is more GLP-1 in presence of insulin resistance, suggesting us that there is this insulin resistance, which is a stress maker for the islets. So really stress, increase alpha, increase GLP-1, and then possible increasing effects. And when this fails, then maybe less insulin is secreted and maybe diabetes appears. Diabetes history, yes, obviously that's another important point which might give us an idea on what's going on. There are many variables which might influence this, but I'm really, once again, we know that we are not looking to the appearance of diabetes. We are looking on how these islets are compensating for insulin resistance, whatever is their destiny to diabetes or not. It's true that for the answer to the surgeon, family history of diabetes might be important, but really, once again, it's not that important in terms of the fact that, for example, as mentioned, the very obese and very hyperinsulinemic patients who is expressing already all the compensation mechanism in order to have enough insulin to cope with the insulin resistance. When you remove half of the pancreas, then you will get diabetes after the surgery, while maybe a patient who might have some kind of history of diabetes but has no other, let's say, triggers for the appearance of diabetes and insulin resistance and is doing all prevention, maybe still the insulin secretion is normal, and after the surgery, maybe diabetes does not appear at all. So it's really stressed islet, remove half, and the remaining is not able to cope with the insulin resistance rather than other major mechanisms which might be there, but I think are less important than this way to compensate for insulin resistance. There is a third question, but I didn't remember. Fourth question, but I don't remember it.
The reasons why those people underwent pancreatic surgery.
Okay, this is the first thing that Teresa did for, I think, 6 months at Jocelyn. Nobody believed that there were some kind of neoplasia, invasion, inflammation, something in the pancreas. There is nothing there. The vast majority, if not all, of the subjects underwent surgery for a tumor of the papilla ovata, which which is something very symptomatic for jaundice. Then they put the stent. They don't have jaundice anymore, but the tumor is there. So in order to this patient for being cured is just to remove, unfortunately, the whole head and the body of the pancreas, which is good for us because we get access to these tissues, but it's not good for these patients, of course. So usually it's a tumor of the papilla ovata, not a pancreatic tumor, and we once again excluded that there were any kind of inflammation or tumoral invasion in the remaining pancreas.
Stefano?
Andrea, this is very elegant. This is very elegant. Is the model that you are proposing, or GLP-1 is a sort of a adapting process or a stimulant to the performance of the beta cell. GLP-1 most likely comes from the alpha cell. So I was wondering whether you can factor in the glucagon, and wondering whether the glucagon increase that you can see also in diabetes may be the initial potential trigger for insulin secretion, and then the GLP-1 comes in, because most likely there is a sort of reciprocal activation of PC1 and PC1-3 that is, the converting enzyme for production of glucagon and GLP-1. So I'm really wondering if you could see a balancing through the history of the attempt to compensate for the insulin function in these individuals from glucagon to GLP-1. Also, on the light of the fact that there are the old theory from Roger Agner suggesting that there is no diabetes without if you get rid of the glucagon.
Well, I'm not that sure that really without hyperglucagonemia I don't get diabetes. We know that glucagon is even be proposed as a therapy for obesity. You will know in the future. So maybe actually, as you mentioned before, hyperglucagonemia, or at least the increase in alpha cells, for sure, is a kind of mechanism of trying to compensate for the poor, or let's say the biased, the stressed islet cells of our insulin-resistant patients. Once again, unfortunately, we don't have so many samples, so we cannot really try to understand. We're just collecting pictures, and for sure, this increase in alpha cells and this GLP-1 immune reactivity come as a response to a decrease in glucose sensitivity of the islet cells. So both of them are mechanisms able trying to cope with the insulin secretion deficit. Whether the increase in glucagon might be in part a mechanism trying to compensate for the insulin deficit is something I cannot affirm, but certainly your idea is very suggestive for this, because it's not that, these alpha cells are just bad companies increasing their secretion for glucagon to make our blood glucose concentration increase. They are trying to do something, and I'm sure that what they are trying to do is probably a sort of compensation for insulin secretion. Maybe, that's my idea, GLP-1, but also other things. Who knows? Maybe GIP or other hormones or other mechanisms. It's something we don't know. So really, the increase in alpha cells and increase in glucagon might be seen not just to deteriorating glucose concentration, but also trying to compensate for the insulin secretion deficit, at least at the beginning.
The very last short question by Renzo.
Just to comment, following your reasoning, glucagon is not just the results of a paracrine dysfunction lacking the inhibition of insulin between alpha and beta cells. You don't have insulin, you have an increase in glucagon.
Generally speaking, yes, but once again, remember that these subjects are not diabetic at all. They are just insulin resistant. So there is no hyperglycemia, no insulin is still sufficient to cope with the insulin secretion. Glucose metabolism is still normal. They have no normal glucose tolerance. What is just present there is insulin resistance, which is stressing islets, and this stress at the islets have increased alpha cells and maybe also increased glucagon. But still, it's normal in terms of glucose regulation. So we are talking about before the appearance of any alteration on glucose metabolism. Really, it's difficult to think that it's already something, damaging our glucose regulation, because these subjects are still normal. But then after the appearance of diabetes, you're right. There are lack of hormones and different hormone productions.